Good afternoon, everybody, and welcome to the latest version of our Great Minds events. We've got a couple of excellent speakers going to be talking to us about advances in dementia. I'd like to first present Professor Paresh Malhotra from Imperial College London. Professor Malhotra is a distinguished researcher specializing in cognitive deficits caused by neurological conditions such as stroke and neurodegeneration. His work has been instrumental in developing treatments for these diseases, and he's actively involved in the development and assessment of new therapeutic approaches. Today, Professor Malhotra will be sharing insights on the mechanisms leading to dementia and how these relate to diagnosis. So please join me in welcoming Professor Malhotra.
Thank you very much, Simon. And sorry to everyone for the delay. Hopefully we'll be able to get my slides to work and you'll be able to see them shortly. Please let me know if they're not showing. So just to quickly say that I have a number of roles as a researcher and within sort of dementia research at Imperial College and in the UK, but my most important role for the purposes of this talk is as a consultant neurologist at Charing Cross Hospital in West London. And I think one of the most important things that I have to do in that role is really just define what we're talking about when I see people in my clinic on a Monday morning in Hammersmith. So first of all, the key word in what we're talking about, dementia. And I'm sure everybody on the call knows this, but I need to remind myself before the beginning of every clinic to make sure that I don't mix up what I'm talking about and I'm not clear when I'm deciding what's going on with someone and what we need to do next. Dementia is not a specific disease. We are not describing the cause of the problem when we say someone has dementia, but we are describing the degree of problems that they have. And it really means when people are unable to carry out the things that they normally do because they have a brain condition that is affecting their ability to do this. So they are unable to find their way around. They might be unable to read a book or concentrate on a talk, unable to prepare a meal, and unable to have a normal conversation with family and friends or as part of their work. And the key condition that we think of in this context is this one called Alzheimer's disease, named for this man on the left, Alois Alzheimer, who about 120 odd years ago described what he saw under the microscope in someone who had in the brain of someone who had suffered from dementia and then gone on to die because of it. And he described under the microscope unusual things that you wouldn't see in a normal brain, these collections which he called miliary foci in the cerebral cortex of this woman's brain. And this bit on the left there that you can see, let me get my pointer out here. These areas are called amyloid plaques and occur outside the cells of the brain. And within the cells are another type of pathological protein deposit, which we don't see in the healthy brain, which is called tau. And these two collections, conglomerations of protein, one outside cells, one within cells, are the hallmarks of diagnosis. So the definitive diagnosis of Alzheimer's disease, until very recently, has been based on post-mortem examination of the brain, looking at someone's brain after they have died and saying that people can find evidence of amyloid and tau. And that's Alzheimer's disease. And really, when we talk about it, we shouldn't just talk about the person who described it 120 years ago, but we should also mention the woman whose brain he was examining. So this is August Data, who is a woman in her 50s, admitted to what was then an asylum with symptoms of paranoia and cognitive impairment, and she never really made it out of that asylum before she had the post-mortem and her brain was being described. And Alzheimer's is not the only cause of dementia. And this is really why we need to think carefully about what we're saying to patients and their family and why we need to think about the processes that are involved in diagnosis. As I said, dementia is an umbrella term, what we call a syndrome, for the loss of thinking abilities, particularly memory. But then we have all these different types of causes. So when you're talking to a dementia specialist, they may often focus on these diseases of the brain, going from Alzheimer's disease through what effectively are strokes and cerebrovascular disease, frontotemporal dementia, more rare diseases such as CJD. But we also have diseases that we wouldn't normally think of in the context of dementia, even head injury, but also conditions such as HIV and AIDS, and diseases of other parts of the body. So really severe renal failure, kidney failure, and liver disease can look like a disease of the brain too, but the initial problem is taking place in another organ system. So we need to have a bit of a broader approach than you might think when we see patients. And the idea we give, and often this comes across in talks and newspaper articles, is that we might have a quick chat with patients and their family, might do some sort of examination, and then we'll have pictures of our lovely scans and our clever tests and our new and very modern ways of making a diagnosis. And these modern ways of making a diagnosis, as you're going to hear from Amanda Heslegrave shortly, who leads a world-leading laboratory in developing new tests, are very, very helpful indeed, but they only work when they take place in the right context. And that context is understanding what is going on with a patient and knowing why they have come to clinic, what problems are affecting them, what sort of time course they've taken place over, and then we go on to our examination and investigations. And I think if there's one thing that I'd like to get across today, it's that. And this is this history that we take. Obviously, we have to ask someone why they've come to the clinic and what they're doing there, what they think their problem is. But in dementia, we have a particular problem that doesn't really occur so much in other disease conditions. It's where the patient themselves often won't notice their own problems. Sometimes they do, sometimes they're aware of memory deficits and other problems, but sometimes they can't notice it themselves and they feel they're doing okay. So as important as any investigation is speaking to someone's family and friends or their spouse. And that sometimes means a separate phone call and almost always means a separate conversation where you can get to grips with how someone's activities of daily living, their particular things that they do, how have they been affected over the last 6 months, the last year, the last decade? What has changed from what this person used to be like? Then we can come to some sort of examination, and this is one of the most famous ones, the mini mental state examination. And if you can see, it might be small, the font there, but not everybody might be able to get all these questions right. This is a 30-point scale that's been in use for 40 odd years, and it's a bit crude. It's helpful, and it gives us an idea of what's going on, but to compare one person of a different level of education, different language, different background with another requires a little more insight than just comparing the crude numerical score. What's much more useful, actually, is just to talk about things that people like. So ask about what's been going on in the family recently, the sort of things we all know about, whether someone's been ill, whether a family member's been to visit recently, where the most recent family holiday was. And then most people watch the news or follow sport, they have a favorite football team, to ask them a bit about that. And if someone says that they're an Arsenal supporter, you'd expect them to know the score from day before yesterday. If someone says that they're a fan of cricket, you'd expect them to know the name of the captain of their team. And just to go through things in a bit of detail with respect to what someone's interested in and how much they're still on the ball with respect to those interests. And you can go to simple things like asking what the route is that they took to the hospital. And then, as I said, it's essential to ask family and friends before going on to one of our more formal cognitive screening tests, which are still pen and paper and can give us an idea of what's going on. And then we come to the more fancy, if you like, tests that you see pictures of when we have press releases and news articles. And the most famous one, I think, still is an MRI scan. And this is what we call a coronal slice, so a slice in the plane of the face. So as if we've gone backwards from someone's face towards the back of their head, and this is halfway through. And I can tell you that this scan shows the brain of someone with Alzheimer's disease. But it's not quite as simple as that. So first of all, when someone looks at a scan, it's exactly that. It's a clinician, a radiologist, a qualified doctor, but still giving their opinion about what the scan looks like on the basis of its features. And they have to compare it, like everything else, in context. So the areas we're thinking about, particularly in terms of Alzheimer's disease, are these areas of brain here. So this gray bit is brain, this black area is fluid, the cerebrospinal fluid, which exists in all our brains. And there should be black area like this, but it shouldn't be this wide. And it's only when you look at the brain of someone who's healthy, and in fact 25 years old, where that black area is just a slit, that you realize that there might be something wrong with this person's brain. And it's only when you compare and start to compare lots of brains, these are both healthy, that you realize that the brain, like our skin, in fact, changes with age. So my skin doesn't look the way it did when I was 20. And if I'm around in 20 years' time, it will look different. I'll have accumulated wrinkles and blemishes, and I won't know exactly when any of those appeared. It's just my skin will have generally changed. And the same is happening on the inside. So the brain itself shrinks as we get older, and it shrinks in a relatively predictable way. And it's only when we have a diseased process like Alzheimer's disease that it will shrink in a different way. And our colleagues from the radiology department would be able to describe it and be able to spot it. So this, I hope you can see, has more black. There is more fluid in our patient's brain, and the brain itself has shrunk. It's been eroded, if you like, by the processes I've described earlier, that buildup of amyloid and tau, and the combination of those appears to cause cells to die off and the brain to get smaller. And because the bits of brain that are affected relatively early on are critical for memory, that's one of the areas that's affected first in this disease. So this is Alzheimer's disease, and this is what it looks like typically on a scan, but an MRI scan won't always show those changes. Those changes won't always be spotted by the radiology doctor, and sometimes the changes will be slightly different. They'll be what we call atypical. But we can, on the whole, tell it apart from another sort of condition, which is frontotemporal dementia. And this is a relatively common disease, tends to happen a bit more in younger patients and maybe more genetic, but people will present a bit differently. They're less likely to have memory problems first off, but more likely to have problems with behavior that might be noticed by their families, problems with more complex tasks and planning. And those problems may not come off on one of those standard pen and paper examinations. We may not see things there, but when we get the sort of cardinal, the key symptoms described by relatives, and when we see a slightly different picture on our MRI scan, where there's more shrinkage on these bits here rather than in a very precise area in the hippocampi, those memory areas I described to you earlier, then we can start thinking that someone might have frontotemporal dementia. But these still are clues leading us towards the diagnosis rather than definitive tests. Another thing that's increasingly talked about is vascular dementia, and this refers to when someone has strokes or stroke-like changes, which are demonstrated by these cotton wool-like appearing areas in the brain that surround the fluid-filled spaces, the ventricles here. And sometimes people might have had a clinical stroke. They might have presented to hospital acutely as an emergency, but sometimes these problems occur in a stepwise way, and it's only when they have a scan and we look at their risk factors and they have the risk factors associated with stroke, like high blood pressure and high cholesterol, that we come closer to the diagnosis and we can try to work out what's going on. And the last thing I want to mention in this part of sort of our imaging and scanning part of diagnosis is the use of PET scans and how we can sometimes label a substance with a radioactive label and inject it into someone's bloodstream, and then it will label something in the brain. And here we're labeling a type of receptor in the brain for a certain substance, dopamine, which is critical in diseases like Parkinson's disease, and also the dementia that's related to Parkinson's disease, which is called dementia with Lewy bodies. And we can do this sort of scan called a SPECT scan. And on the left, we have a normal scan here, where this person has the normal distribution, the normal array of dopamine receptors. And here in this individual, they're much smaller. And this sort of patient is much more likely to have visual hallucinations. Their thinking might go up and down, and they might start to be developing the signs that we'd see in Parkinson's: stiffness, tremor, slowness of movement. So all the things I've mentioned so far, they're things that give us clues to the presence of those proteins that I've mentioned. And a typical pattern of someone's clinical problems, a typical scan, will drive us towards the diagnosis. But as I mentioned before, it's not definitive. We can't be sure that those proteins are there. And we really are only starting to be able to determine whether those proteins are there in someone who's alive with newer tests. And they're often referred to as biomarkers. So we can look, particularly in Alzheimer's disease over the last 20 to 25 years, for the presence of these biomarkers in the brain using tests. And this really started off by being able to look at the cerebrospinal fluid. So the same fluid that bathes the brain also bathes the spinal cord. And at the bottom of the spine, as shown here, there's a fluid-filled sac that's continuous with the sac that surrounds the brain. And if we put a small needle into it, it's called a lumbar puncture or a spinal tap, we can take that fluid and we can analyze it for the presence of these proteins. And so spinal taps, lumbar punctures have been used for a very long time to diagnose things like meningitis and encephalitis and multiple sclerosis. But sort of 20 odd years ago, we began to be able to look for the presence of amyloid and tau and indicators that they were in this fluid too, and could tell us about what was going on in the brain. And so this has transformed our understanding of the processes that cause Alzheimer's disease. And it's also slowly begun to transform our ability to diagnose. But as you might imagine, and as you might be imagining now, having a lumbar puncture isn't for everyone. It's difficult to arrange and it's hard to organize. And it's only been done really when diagnosis is difficult, or if someone's presenting in an atypical way, or we want to be absolutely sure of the underlying condition, or as part of research. Something that's brought things on even further is our ability to use that PET scanning technology, which I mentioned, where you make a radioactive label for a substance to show the amyloid in the brain. And so we can get this radioactive tracer, inject it, and then look at the brain patterns and see whether amyloid is present or not. And this, again, has helped transform our ability to diagnose Alzheimer's, both in the research setting and in clinic. But it's unreliable and it's very expensive and it's very difficult to do on a large scale. So really only at Charing Cross here where I work do we do this regularly in the UK, and elsewhere throughout the world it's scattered with respect to how much access there is to being able to do these amyloid PET scans in the clinical setting. In the research setting, they really have made a massive difference. And so the biggest step in this world really is taking place now. And you're going to hear a lot more about that from Amanda when she speaks next. But hopefully, blood tests are really going to change the way we think about everything I've discussed. So just to come to a close, I've really just touched the surface of what happens with respect to clinical diagnosis and our understanding of disease mechanisms and their relation to that. But it really does make sense to go back to basics when thinking about these things. And so first of all, when the diagnosis is being made, we have to identify that someone has dementia. So that's part A on this dictionary definition. We're identifying the presence of a problem, really, and a problem that's sufficient to affect someone's activities of daily living. And then we can diagnose the underlying cause using some of the advanced technologies that I've mentioned already, but also very much seeing it in context, in the context of what problems an individual has and how long they've been there and what's going on. And what's key to this, and really isn't mentioned very often, is the need to have a team. So you don't have just one person in the clinic who's making the diagnosis. You have that person in the clinic working together with a multidisciplinary team. So as I mentioned, at Charing Cross Hospital, we've been doing these amyloid PET scans probably for about 12, 13 years now. And this is the group of individuals on the right here who helped set up that process. And then we've got a radiologist, someone with expertise at looking at scans, a nuclear medicine physician, someone who knows all about those PET scans. And we've got my colleagues, Dr. Richard Perry, who still works with me here, and Professor Richard Wise, who sadly has passed away. And it was with these individuals that we set up a multidisciplinary meeting every week or so to discuss cases, to discuss what test would be most sensible next, and to work out how we'd make a diagnosis. And it really does take a team to work through this, both at the research level and at the clinical level, before we can try to help patients and their families and start thinking about treatment and management. So I'll finish there, and I'm happy to take any questions before Amanda speaks, if that's how you'd like to do things, Simon.
Thank you very much, Paresh. Excellent talk. I probably should have said at the beginning, please use the chat function in YouTube to ask any questions that you have of Paresh. While people are thinking about any questions, Paresh, you talked about a variety of different techniques and different capabilities to help that diagnosis. Are there any different subpopulations of the population that need to be considered differently within those tests, or can we use sort of the same techniques across everybody?
I think it's the subpopulations goes to individuals, really, that each person needs to be considered in the context of their whole history. So sometimes if someone has medical problems, that can affect how some of these tests are done or interpreted. You know, if they've got kidney problems, we can't do some of these tests. If they've got a pacemaker, they may not be able to have an MRI scan. In certain ethnic populations, the results are slightly different. That's why, you know, you can't, when people are referred to clinic, we prefer to get the tests after we've seen the patient on the whole, so we know what the right thing is for that person in that context. And even the reports we get about tests, they have to be interpreted very carefully in the context of that individual, because a different result means a different thing for different people. And as I mentioned, those changes of the brain over time, sometimes the brain has not changed as much as we think it has in the last 10 years. And it's always looked a bit different from the average brain for whatever reason, or someone has had a head injury in their youth, which has led to long-term changes. So it really does take quite a lot of time to go through someone's medical history and go through the problems that they're suffering from now.
Okay, thank you. Again, please put any questions that you have in the chat. Paresh, you also talked about different dementias, and Alzheimer's obviously is the most common. My understanding is, though, that things are not unique. So it's not somebody with Alzheimer's or somebody with vascular dementia or somebody with dementia with Lewy bodies. There are often combinations of different things. Does that make things more difficult?
It does, and I think as clinicians and as society, we've not really acknowledged that yet, even though the science tells us more and more that it's the case. So certainly in more elderly individuals, as we get above 75, it becomes more common that there's more than one thing going on in the brain. And certainly the combination of what we call vascular changes and Alzheimer's disease, those changes are extremely common once we get over 80. So I think well, I was about to say in 10 years, perhaps in 5 years, our definitions will change. And one thing that I wanted to mention at the end of the talk, and I forgot to do so, sorry, is that things are changing constantly. And so we speak about these things as dogma, as fixed ideas, but actually they keep changing every year or two. And it takes a while to realize that these things are in flux. More research will tell us things, and you know, in the future people will think, what were they doing there? So we have to do the best we can with the tools we have, but we also have to be honest about what's lacking still and what knowledge we don't have.
Thank you. An interesting question from our audience is, are these tests, are there more recent tests that are available privately? So what's the balance between health service, NHS tests and private tests?
I think so. In the NHS, all the tests I've mentioned are available, but there are pockets of variability that are geographical or just luck sometimes. So some places are available, some tests are available in some places, and it might just depend on who you see. And the same occurs privately, to be honest. In quite a lot of places, there are some things that people are more used to doing and some people less. So there is a bit of a gap, but less of a gap in sort of the overall coverage. It's just that in the NHS, there tend to be more pockets. And then in the NHS, there are different sorts of services, and those different services, there may be old age psychiatry clinics, there may be neurology clinics, there may be clinics run by what we call geriatricians or care of the elderly physicians. And each of those have their different practice and different way of doing things. And it's about having the right combination of tests for the right person, rather than having a blanket coverage of doing everything.
Okay, a big question here, Paresh, and apologies if it's not, I know it's not really your area of expertise, but can AI assist us in this?
Yes, is the first answer. So yes, but in the long run and with much less hype. So I'm sure it will change what we do and how we do it, but the hype that is around it and the sort of jumping to think that it will solve all our problems at the press of a button is, I think, very premature. So if you think about all the things I've mentioned and the real need to see people in context and to think about their complex histories and their complex activities of daily living, and to think that AI might solve that very quickly is not going to be that straightforward. But certainly with some of the aspects of what I've talked about, for instance, comparing brain scans with much bigger data sets and to give us initial ideas and to help us with these things, it'll start to get introduced more and more, and it is already being introduced in some settings in the UK.
Thank you. A type of question that does come up in various talks that we've had is, for someone who has 2 copies of the ApoE4 allele, what access is there to private medical cover, and is it possible or advisable to seek tests to look for early signs, even pre-symptomatic?
So another thing that I should have mentioned that I forgot to do so is that the only thing that will really change how we do things within the NHS and more widely is research. And so I would recommend, you're already involved in great minds, I think the majority of the audience, but I would recommend using things like joint dementia research and enrolling in systems like that for things that are appropriate. From the point of ApoE itself, there is no approved clinical approach to someone who does not have symptoms. And then our approach with respect to diagnosis would be the same as it would be without having ApoE. And it's important to remember that 20% of the population will carry one ApoE4 gene anyway. So it's a relatively common thing, but we know that it's the most common risk factor for the development of Alzheimer's disease, and that's why we need to consider it in our thoughts. But it's not being done yet as part of routine clinical practice, and our approach is generally the same as it would be with someone presenting with those symptoms. So they're the same sorts of symptoms I've talked about, difficulties in doing the things that someone has always been doing.
Great. And on the diagnosis side, Paresh, how is the diagnosis managed with British Sign Language? So deaf individuals, any kind of language barriers that there are there?
There are definite barriers. There are great difficulties. There are a couple of clinics that are specific to people with hearing impairment and to help diagnosis there. But again, like we talked about pockets of availability with tests, there are only pockets of availability with the special expertise to do this. And otherwise, these problems aren't always handled perfectly.
Okay. And maybe I'll ask this as the last question, because I think it is getting closer to the area that I think Amanda's going to be talking about. But how close are we to getting a test that GPs can use? And will the work that we're doing at the moment enable such a test to be incorporated at GP level to be rolled out and made more widely available?
So Amanda is exactly the person to answer that, and her talk will answer that. But just to say that this is probably the biggest thing that's happening in our world at the moment. And a lot of what we talk about on a weekly, if not a daily basis, is how exactly is this going to be implemented and how do we do things? And Amanda is the ideal person to tell us about that technology.
Okay. In which case, thank you very much once again, Paresh, for an insightful presentation. And we'll now move over to Amanda's. So our second speaker today is Dr. Amanda Heslegrave from University College London. Dr. Heslegrave is at the forefront of innovative diagnostic research in dementia. Her expertise focuses on how researchers are now able to use blood biomarkers for diagnosis, and which will be a significant advancement that could transform how we detect and monitor dementia. Her work represents an exciting shift in diagnostic approaches and may lead to earlier and less invasive detection methods. So please welcome Dr. Heslegrave as she shares these developments with us.
Hey, thanks very much, Simon. Can everyone see my screen? Is that okay?
I can see it fine, thank you. Yeah.
Excellent. And thanks, Paresh, as well, for that very interesting clinical look at things, because obviously that's a part of it I don't normally see. But today I'm going to talk about basically ways that AD diagnosis from a blood biomarker point of view is going and how we can make that more inclusive. So I'm part of the UK Dementia Research Institute, and this institute is made up of a number of different sites across the UK, which was kind of formulated in 2017 to make dementia research more kind of inclusive across the country, to make sure that all the best research being done was able to be supported in a cohesive fashion. And so my lab is at the Fluid Biomarker Laboratory at the UCL DRI. So we're based at the UCL Institute of Neurology in Bloomsbury, and we have a specialist lab, really. I think probably one of the most specialist biomarker labs for neurodegenerative disease in the country, if not the. And so we measure biomarkers in fluids. This is our daily business, and we've got the expertise to do that, and also the equipment and the knowledge of dementia and neurodegenerative diseases. So in 2021, we were lucky enough to be able to get funding from the DRI to set ourselves up as a biomarker platform. And we wanted to do that because many people, many researchers in the UK, clinical researchers like Paresh, had cohorts set up already, and we've been collecting samples for a long time. But now what they needed was their expertise and the ability to measure these samples so that these results could inform dementia research. And so we set up the lab to undertake the larger studies, although we do studies of any size, but that are going to really help people to get that research into clinical trial setup and eventually treatments for all neurodegenerative diseases. So what's a biomarker? I mean, Paresh did go into this somewhat, but it's basically something that we can find, a substance, a protein that we can find in blood or other body fluids that gives us a sign of a normal or an abnormal process or a condition or disease. We can use them in different ways. We can use them to diagnose, we can use them to prognose, we can stage diseases with them, but we can also, and this is becoming more crucial, I think, as research is moving forward, monitor treatments also. So this is the people in the biomarker factory. I co-lead the lab with Professor Henrik Zetterberg. He's a world-renowned biomarker specialist from Sweden, who I've worked with for 12 years now or so. And the rest of my team, we're a team of technicians and research assistants who are all knowledgeable and expert in running all the different kind of technology that we have. So why are biomarkers so important right now? maybe this is redundant after Paresh, but what I say is that they've always been important, but in neurodegenerative diseases are not something that people have automatically thought of because they've been so hard to access. Obviously, we can't access the brain during life. And so, as Paresh told us, we used cerebral spinal fluid. But this is an invasive procedure. It's not something I think that people in this country expect, although in Europe it's much more common, I'm told. You need to go to a hospital to get it done by a specially trained, expensive clinician, and there could be side effects such as post-lumbar puncture headache. So this is not something you undertake lightly. Now, blood biomarkers are changing this. It was about, I think this is a bit out of date, up until about 10 years ago, I'm going to say, it was thought that we'd never be able to measure the proteins that are associated with the brain health in blood. And this is because in spinal fluid, we know that this fluid bathes the brain, and so you can understand that the proteins associated with the brain are going to be found in that fluid. They also will be found in blood when they've kind of like secreted out of the spinal fluid into the circulation, but at much, much, much lower amounts. And so they're really difficult to find with old technologies. But in about 2015 or so, some technology called single molecule array technology was developed by a particular company, and they showed that they could measure proteins that were indicative of brain health in plasma or serum, which was a real breakthrough. And as recently as, I think last year, a paper was published that showed that this company was making a test that was actually able to identify Alzheimer's disease pathology, as well as the best spinal fluid tests or PET scans, and the PET scans with the radioactive traces that Paresh talked about just before. So that's like kind of game-changing, really. So what does this mean? Well, it means that we're well on the way to validate blood tests to identify those with signs of Alzheimer's disease in the brain, making this process much cheaper and much less invasive. And when I say signs of Alzheimer's disease in the brain, the tests that we have so far that I will talk about today anyway are able to tell us about amyloid plaques in the brain. Now, this just tells us that there's amyloid plaques in the brain, and that on its own would not be enough to diagnose someone with Alzheimer's disease. As Paresh says, you need that full story, you need the clinical opinion, you need the information from family, and you need, the cognitive tests as well. But what these tests can do is tell us very accurately if there's amyloid plaques in your brain or not. So one of these tests, and this has been around now, I think since about 2022, is a test called phosphorylated tau 217. And we can use this, take someone's plasma, and we can measure this protein in that plasma. And here we've got, and I'm just going to try and find my pointer if I can. Ugh, I can't, I don't know if you can see this pointer, but that's fine. We've got 3 different cohorts. This is 3 different groups of research groups. And so just called different names from different parts. I think most of them are American. And what these charts are showing is that in people that we've already proved, or we know have got no amyloid in their brain or no tau in their brain, this protein is very low. Where people have just amyloid in their brain, but no tau in their brain, it's higher. But with people who've got both amyloid in their brain and tau in their brain, the results are the highest. And this is recapitulated in each of the cohorts. And so we know that amyloid is a very early sign. Amyloid deposition in your brain is an early sign. The tau comes later. So in these people that are A+, we call them, and T-, they're on a trajectory likely towards Alzheimer's disease. And that's what we can see here. But these measurements are all made in plasma. And so something that even 5 years ago, we wouldn't have been able to do. So because there are now treatments that are moderately disease modifying, I'm going to say moderately because we hope very much that next generation drugs are going to be, much more better and approved in this country. But because we've got these, we need now to really think about diagnosing people and using biomarkers to do that. So, I mean, this was just, this is a test that's available in the States by a company who makes super sensitive technology, but have now moved into kind of trying to provide a clinical service as well by offering a test called a multiplex test, which uses the protein I was just talking about before that you saw how well that performs, and some other proteins that give us information about brain health to actually try and refine that diagnosis. Because what we find when we just use one marker, such as phosphorylated tau, we see people who are very high, we see people who are low, and with these people, we can be really quite confident that they either don't have any pathology in their brain at all, or they have the pathology, which means they will go on to develop Alzheimer's. But what we see is a middle section, sort of people who are intermediate, some of whom might not go on to develop Alzheimer's disease, some of whom are intermediate because they are moving on to that spectrum. And so what this company are trying to do is use a number of different markers to make that intermediate area smaller. Because if you went for say we were offering regularly blood tests and you go for this blood test and you're told you're intermediate, then what do you do? Well, normally perhaps we would think about a PET scan or a CSF test. And obviously it'd be much nicer to just be told you're in the not going to get Alzheimer's disease section. But anyway, but a clear diagnosis is what we want. So that test I just showed you, that's available in the States, because in the States there are actually insurance companies that are covering the treatments such as Leqembi and donanemab. And this is another test available in the States where they use a different technology called mass spectrometry to test basically the same proteins and give results. And this is available to people to just order so that they can give them to their private doctor in the States and get their drugs with their answers. So that aside, one of the things that we are really thinking about at the moment, because the research is suggesting that we've got good enough biomarkers to be able to diagnose amyloid pathology. Now what we need to do is think about how do we make this more accessible. And when I say make this more accessible, I do mean diagnosis, but I also mean, because we have not got perfect treatments by any means yet, access to trials. How can we make it easy for people to volunteer to be a member of a trial? And an exciting possibility that we're working hard to validate in our lab right at the moment is the use of blood and plasma spots. Now, this means that you can actually just use a drop of blood from your finger onto a specialist device to collect your blood in a measurable metered amount, and then use that and then post that, actually dry it and post it, so that you don't need any special equipment such as a centrifuge or a ultra low temperature freezer, but you just post this device off to the lab where it's going to be analysed and get your result from that. And I've just, here's just pictures just showing you the kind of things that we're looking at the moment. We're looking at the dried blood spots, which is literally kind of like blotting paper that you drop your blood onto, which is kind of the least sophisticated, I'm going to say there. And then there's more sophisticated items like the Capitana dried plasma spot. This one, you put your blood onto the spot and it's actually filtered through a membrane, and the substance that we're left with is plasma-like. I'm not going to say it's exactly plasma, but it's plasma-like and much more amenable to the tests that we do. So there are various different devices out there, and actually a lot more being made and like invented at the moment, because I think that people realize this could be such a big market. I mean, not only for say getting people into trials, because it would mean that they wouldn't have to come into so many appointments. They could do it at home and maybe do a digital cognitive test at home as well. The possibilities here are really exciting, but also for those countries where there just isn't the infrastructure for them to be able to process blood like we do in this country. So this could like really make things a bit more equitable. So we're validating at the moment, looking at things like how many discs, what buffer, which is just the liquid that we elute our spot in, the temperature we do it at, and the measurement methods we do it at. Now, what we're doing at the moment is just comparing the measurement we get from the blood spot or plasma spot with normal plasma, what we would get from a vein. And so, although all of this is from a vein for various reasons, and what we see is that we're able to correlate these measurements really quite well with these two analytes in particular. Common analytes that we look at, neurofilament light gives us an idea of neurodegeneration, i.e. the breakdown of cells in the brain, and GFAP is a marker of inflammation, I'm going to say, important in neurodegeneration. We can also, we can do it on a different we've got various different sensitive platforms in the lab, and we like to see which one's going to be best, and if the results are comparable, and they are. What about 217, the wonder protein biomarker I've been talking about? This is at very, very low concentration in the plasma, whole venous plasma. So in the finger prick, it's going to be even lower. However, we've just started that validation, and we're getting some decent results. More than that, we've now got technology that enables us to measure many, many proteins in a drop of blood. And there's a panel called the CNS disease panel, and this panel contains lots and lots of proteins that we know are relevant in the brain, alongside lots of proteins that tell us about inflammation, which, as I've just said, is an important kind of pathway in neurodegeneration. So this is a really new technology. We've been using it for less than a year at the moment, and so there's lots of results coming in and lots of analysis being done. But in terms of the dried blood spots and the dried plasma spots, I think that this will be amazing, because the amount of information we can get from just, that small amount of blood, I think, is incredible. So bringing blood tests into the clinic, I think somebody was asking on the question how soon this will be. And yeah, I think actually this is like a little bit of an old slide now, I think. A couple of years ago, Alzheimer's Research UK, the NIHR, the People's Postcode Lottery, and Alzheimer's Society all put their heads together and their money together to make what we call the Blood Biomarker Challenge. And 2 groups or consortia were awarded funding to make it happen, to make these blood biomarkers available on the NHS. And so there's a team at UCL that are involved in this, Professor John Schott and Dr. Ashwini Keshavan, and they have, since the start of the grant, been working to get phosphorylated tau 217, the analyte I've been talking about in this talk, onto a clinical chemistry analyzer. Now, this is a machine commonly used in NHS diagnostic labs across the country for many, many different analytes. And so they've been working with a company making a test for p-tau217. And what they've actually done is got this, they had to do lots of work to measure many, many samples to agree cutoffs. You know, what's your low cutoff where someone is negative? What's your high cutoff where someone's definitely positive? What's your intermediate? And can we make that smaller? And then get it agreed by the MHRA, the Medicines Regulatory Authority. And so they've done that, and it's actually now available to memory clinics to order from the NHS lab that is situated about 6 floors above me in this building. So this is brilliant. And another thing they're doing with people volunteering or participants in this study, they're not changing ethics, but applying for ethics to mean that they can collect finger prick samples for me and my team so that we can get much more information on the finger prick samples and how this will help us towards diagnosis in comparison to the real world samples that are going through the clinic. So that was a abrupt ending. Sorry, I think I finished there. So thanks very much for listening.
Thank you very much, Amanda. And sorry, you mentioned there were 2 studies there, and I've been partially involved with the other study in the biomarker challenge, the readout study, which is doing something quite complementary, I think, to the work you're suggesting at UCL, but looking at a broader range of other potential biomarkers that might be coming through in the future. So that's, and it's great to see the two studies working with each other. Thank you very much. There's a question about moving on from diagnosis to sort of understanding the trajectory and the velocity of disease progression. Can we use these wonderful biomarkers to help understand that?
Okay, yes. Now, prior to this meeting, I was thinking about a different talk, and that feeds into this question, really does, because I said that there's different aspects to the pathology that we see in Alzheimer's in the brain. There's the amyloid plaques that we know are formed early, many years before symptom onset. But then there's the tau pathology, which consists of tangles and aggregated tau in the brain, which is later than amyloid pathology and much more goes with symptoms. And I was at a conference just last week where they were talking about measuring different fragments of tau in plasma that correlated much more with the tangles in the brain, so that we could be able to use these markers to tell us where we are with tau accumulation in the brain. And it correlates very well with tau PET, which is a way of visualizing the tau load in the brain. That is actually, this is only I think Paresh can agree with me here, it's only a research use tool at the moment. It's not for clinical use of tau PET, but we can see that these biomarkers in the blood track with the tau PET. And that's really important, because I think that this will enable you to look at someone and tell them how far they are on in disease. So yeah. And that won't be the only one, I should say, but at the moment there's an awful lot of work going on in the tau area.
Thank you. And you've talked about p-tau217 and a wonder protein that's looking as though it's going to help us tremendously, but that seems to be mostly focused on Alzheimer's. If we're looking at other dementias, is there a p-tau217 for other dementias, or is that not quite?
I wish there were. There are proteins we know are important in other diseases. For example, alpha-synuclein is an important protein in Parkinson's and dementia with Lewy bodies, and a protein called TDP43 is important in actually a lot of neurodegenerative diseases, not specifically Alzheimer's disease, but the tools to measure these are much less advanced, let's say, than the ones that we use for the phospho-tau or the amyloid. And I think part of the readouts, is it the readout or the readout study is to look at those other dementias where we have different biomarkers that we need to develop and make into, you know, more useful tools. And another thing that could be possible is, and we might find this by using the panel that I was just speaking about, is small groups of biomarkers that together give us information about specific diseases. This is the hope that we'll be able to do that, because we've focused on Alzheimer's disease and we've got pretty good tools now, and now we need to kind of move that over and make sure that all of the neurodegenerative conditions get attention and the biomarkers that they need.
Right, agreed. And Ruby's asked, how do you go about measuring the p-tau217 in the blood spot, since it is at such low concentrations? How do you make it viable for use?
Well, I mean, because the technologies that we've got are so sensitive, yeah, I mean, so the game changer in all of this was the Quanterix Simoa, which is single molecular array technology. This is what that is. And it made measurements much more sensitive by compartmentalizing the actual measurement detection at the end. So you basically capture your protein on a bead, on an antibody on a bead, and then you place that bead into a well, only small enough for that bead, a femtoliter, if that means anything to you, size well. And then you're able to look at that bead, you image it with a camera, and you're able to see if there's just one protein on it, or molecule, or more than one, or a lot. I mean, it is the technology that's enabling us to do this. I mean, we have to work to optimize the conditions to make sure that we're giving in the elution buffers and stuff like that, make sure that we're giving the best conditions to get all the protein out of that. And sometimes we, you know, maybe we use 1 blood spot, 2 blood spot, 4 blood spots. That's what we're kind of trying to work out now. What are the best conditions to be able to measure as sensitively as possible?
Okay, thank you. This may be a question more for Paresh, but welcome thoughts from either of you. But Chris has asked the question. His father died of Parkinson's. His older sister has dementia with Lewy bodies. Is living with dementia with Lewy bodies, and Chris has got a diagnosis of MCI, but functions well. Are all of these conditions linked?
That is for you, Paresh.
So the first thing is to say that it's never wise to comment on someone's individual problems in this sort of setting, just because it's always too brief and we can never get the nuances and the specificities of someone's family history and what's wrong with them. I can say that we know that Parkinson's disease and Lewy body disease are caused by the same underlying protein and underlying process, which Amanda mentioned just now, the alpha-synuclein. So the researchers told us that on the whole, when people start to get conditions in their 70s, they're less likely to be genetically linked than if they're affected at an earlier age. So for instance, in their early 60s or 50s. But as I said beforehand, there's a lot that we still don't understand about all these conditions. And in addition to that, we can't be, it's very difficult to say specifically in the sort of context of this type of talk. And even in a clinical consultation, it's hard to be definitive about some of these issues.
Okay, in which case, thank you very much, Amanda. Thank you also, Paresh. They're the two talks. I said at the beginning, but unfortunately, I think it was before our connection was working properly. Unfortunately, Ivan Koichev, who leads the Great Minds study, he is unable to be with us this afternoon. Had a last minute complication that he had to go and deal with. So I have got some slides that Ivan was going to present, which I'm happy to quickly run through. Before I do, just wanted to say thank you to everybody that takes part in the Great Minds Register. The Great Minds Register is growing on pretty much a daily basis. We're very pleased with the number of people that are joining, and also we're getting more and more studies coming through. So hopefully, if you haven't been invited to a study soon, then you will. If you haven't been invited to a study, hopefully you will be soon. Echo what Paresh said before, that particularly in the pre-symptomatic area, if one of the best ways that I think you can help you, but also can help science in general, is by getting involved in research studies, whether it be via Great Minds or join Dementia Research, which we work very closely with, and Paresh works very closely with as well. So join up to these registers, and then you can get involved in some studies. What Ivan was hoping to discuss. And let me just put this on presenter mode. Hopefully that's now visible. Thinking about recent advances and trying to answer the question as to whether dementia prevention is on the horizon. And he wanted to talk through a couple of studies that have come through recently. Firstly, one looking at the shingles vaccine, and some evidence from that study that having that vaccine may help cut dementia, and just to give a little bit more detail to that, there has been in the past a recombinant vaccine taking place, and a live vaccine taking place, and now a recombinant vaccine being made available. And those changes into what is being offered gives us a natural experiment to try and understand how, if and then how this vaccine may be giving some degree of protection to dementia. 100,000 individuals have had the vaccine, so that's the great thing about the vaccine program. It is touching a large number of people, and it is that the studies are starting to show quite a dramatic reduction in dementia. And the study that's been quoted recently is showing a much more prevalent, a much greater reduction in the for females than for males. A 22% reduction for females versus a 13% reduction in males. Exactly why this is happening is ongoing research. We're trying to understand that still. It could be direct action on the virus itself, or it could be a reduction, an improvement in the immune system. And just to give a little bit more colour to that, apologies for the busy graphics, but on the left-hand side here, one study is showing that reduction between the two sexes, so a difference between females and males, that the gap between the blue line and the red line for females is greater than it is for males, showing but both showing a significant improvement. That was published last year. This year, another study published with people that we're working with in Harvard in the US, showing that it is age-related as well. So bigger increase particularly when people are having this vaccine younger. The other area is in diabetes medications. And I'm sure we've all heard of the benefits that are being observed by taking some drugs, semaglutide in particular, and seems to be having impacts in a variety of different conditions. But it now seems to be evident that there is some impact in dementia. Semaglutide is one of a family of drugs called GLP-1 receptor agonists. They are known to lower glucose and it delays the emptying of the stomach. And so that's why they are understood to reduce appetite and are therefore being used in diet control. But it is also being shown that there is an impact on the cardiovascular system as well. So there is some reduction in heart attacks and stroke as a result of this. But equally, seems to be a reduction in kidney failure. It's early days, but it looks as though there is something positive with regard to dementia. Exactly why isn't understood and is ongoing research to try to understand that further. Possibly it is the relationship with the cardiovascular system, but potentially it's other things as well, or possibly some degree of combination of the various factors. So this is showing some of the results at the moment, and looking at the prevalence of the development of dementia on people taking the GLP agonists versus people on placebo controls, and significant reduction in the amount of the number of people that then go on to develop dementia. And that is being shown in terms of these graphics are showing a range of different drugs, and so it is not all of the family of drugs that are being offered to the population that are showing the difference. All are showing some degree of benefit, but the GLP-1 agonist receptors seem to be showing this in a much more pronounced way. So there is something going on within the GLP-1 agonists that are not being shown by other types of drugs that are being offered to the same sets of patients. This is, sorry, a few more numbers showing pretty much the same thing. So they were the two areas that Ivan would wish to share with you in terms of we don't have a cure, obviously, yet, but there are encouraging signs with some drugs that are available. And the benefit of looking at drugs that are already available that are beneficial in other areas is that it's much quicker and indeed much cheaper to get these available for patients, because a lot of the hard work in terms of the safety trials and things like that need to be performed before they can be given to patients have already been done. So that process of developing the drugs so that they can be given out to patients can be shortened dramatically and therefore be given out safely to individuals quicker than it would be if a new drug came along. So that was very briefly a summary, and I'm sure Ivan would have done a better job than I in terms of presenting that. But that's our summary, and I'd just like to say thank you for your attendance and your support for the Great Minds register and study. I am just checking the questions that have come through. There's a question of whether dementia and Alzheimer's is hereditary. I feel unsure about answering that with Paresh still on the call, so I don't know, Paresh, whether you are still there and able to respond to that. You'd answer it much better than I.
Well, no, it's very complicated, but we know that especially when people who are much younger get dementia, then it's more likely to be hereditary. So there are forms of Alzheimer's disease that are hereditary, but they tend to be much rarer. And then this gene that we've mentioned a couple of times, this ApoE gene, in sort of more standard Alzheimer's disease that people get when they're older, that's one of the bigger contributors along with age itself. And so understanding exactly why that gene contributes in that way is critical. And then for the other dementias, frontotemporal dementia in particular is quite hereditary. And then more rarely, Huntington's disease is hereditary. So it depends on the dementia, but there is a hereditary component to some, and some more so than others.
Okay, and apologies, Paresh, I'm picking on you, but one of the other questions that came out, I talked about the shingles vaccine. One of the questions that came up, has been sent in, is, does having had shingles give protection? And
I don't think it's been as easy to study in a way, because these studies are done on such a huge scale that it's only when we have evidence of before and after, or very clear documentation of people having had something, that we can understand its effect. So with this vaccination, it's like a massive, sorry to put it this way, natural experiment, or certainly population-wide experiment, where people all receive a vaccine at a certain time, or the type of vaccine is introduced, and then we can see what happens to tens or hundreds of thousands of people at once. And that's what makes it easier to study. And when it's things like having had an infection like shingles, or shingles is even the recurrence of an infection of chickenpox, then understanding the exact mechanism of what's going on and whether it's related and what the risk factor is very tricky, even in large populations. But a lot of people are following up the work on why exactly there seems to be a link between the vaccination and reduction of dementia risk. And there's a lot of people trying to work out the mechanism and how best we try to enhance that and incorporate that in the way we prevent dementia.
Thank you. And on the other area that I spoke briefly about, the weight loss medications, and there's a question as to whether the weight loss medication is directly protecting against dementia, and would somebody with healthy weight be protected better? Now, I think the research, it's too early in the research to answer any of these definitively. I have seen information to suggest that it's not typically recommended for people of healthy weight to be taking these drugs. But Paresh, again, you're more informed than I.
So there's the bits that are research, and we know that there's sort of something going on, and we want to look more closely. And I think that's what is the case with these newer drugs. And then there's the bits that we know do make a difference. And so, for instance, we know that controlling the risk factors for heart disease in general, of which having a healthy lifestyle, high blood pressure, cholesterol, and smoking, all those things, we know that controlling those helps reduce the risk of dementia overall. With respect to the specific weight loss drugs, the GLP-1 drugs, and the mechanism by which they act, that remains unclear with respect to what effect they have on dementia.
Great. Okay, thank you. I just to add to that, as a result of the interest in this area, we have added some shingles questions to the questions that we ask Great Minds volunteers to answer. So next time you go into the system, please do look at the questions that are there, put your information in, and then we hopefully can then utilize that in terms of recruitment into studies and trials to help further on that information further. So, in which case, thank you both, Paresh and Amanda, for your presentations. Thanks everybody for attending today. I hope you found that interesting and insightful. We will be hosting another similar event towards the end of in the autumn. So more information will be provided on that in due course. But thank you all very much, and I hope you all found that useful. Okay, thank you very much.